waste product, bilirubin, and cholesterol through secretion into the bile elimination in feces. So as I was saying, it is stored into the gallbladder and released when the patient has taken a meal. So after taking a meal, there be secretion of cholecystokin, uh, which is released from the duodenal mucosa in response to a meal. So there be this release of bile from the gallbladder, and 50 to 70% of the gallbladder content will be eliminated in about 40 minutes. That is why it is crucial to evaluate the gallbladder when it is full and the patient has fasted at least 4 hours. For the anatomy, the biliary tree is divided into two uh, hepatic duct, the intra and extrahepatic ducts. So the intrahepatic ducts, they travel along the branches of the portal vein and the hepatic artery, forming the portal triad. So for the intrahepatic bile duct, they formed from large bile caliculi, which come together to form segmental ducts, while the extrahepatic ducts are formed by the right and left hepatic duct, which will fuse and form the common hepatic duct, and fuse the common and the hepatic duct will join the cystic duct from the gallbladder to form the common bile duct. And the common bile duct will enter the second portion of the duodenum through the muscular structure or the sphincter of Oddi as it is known. So the right hepatic duct will be draining the right-sided lobe of the liver. It has two divisions, the anterior division and the posterior division, or sectoral duct, where we have the anterior sectoral duct, which drain the fifth and eighth segments, and the posterior sectoral duct, which drains the sixth and seventh segments. We have the left hepatic duct, which drain the portion of the segments of the left lobe, mainly the second, third, and fourth lobe. On the fourth segment, the caudate lobe, it has a variable drainage pattern, but 78% of people it drains into main duct. So this diagram, which illustrates the intra and extra uh, hepatic duct, where we can see this uh, right hepatic duct, which is formed by uh, the right anterior sectoral duct, which drains the fifth the fifth and eighth segment, and the posterior sectoral duct, which will be draining the sixth and seventh segments of the right lobe of the liver. So they fuse and form the right hepatic duct, while the left hepatic duct will be formed by duct segments of the second, third, and fourth segment, which will form the left hepatic duct, which the left and right will form the common hepatic duct. Here below we have the gallbladder, where we can see that the cystic duct will join the common hepatic duct to form the extra hepatic portion of the common bile duct, and it will enter into, as you can see, this is the duodenum. You can see the D1 and this D2, where the sphincter of Oddi is located, where the common bile duct will join the pancreatic duct and enter into the second segment of the duodenum. On this film landed, we can appreciate the right hepatic duct, where it is in this patient there was stratification of the intrahepatic bile duct, where we can visualize that the posterior, the right posterior duct or sectoral duct is joining in the mid of the right and left hepatic duct. This forms a variant where there is trification of the hepatic duct. So you have a confluence where we can see three ducts meeting at the same place. It will, in normal variants, to have fused before reaching the confluence of the right and the left hepatic duct. So also we can visualize that uh, you can see the gallbladder where a cystic duct. You can appreciate the left hepatic duct draining the left lobe of the liver and the right hepatic duct draining a major portion of the segments of the right lobe, which fuses and form the common bile duct and the common hepatic duct. The common hepatic and the cystic duct will join and form the a common bile duct and at the sphincter of Oddi, the common bile duct and the pancreatic duct, when they will enter into the second portion of the duodenum. So the ducts, they are formed by layers. They are formed by the mucosa, which is lined by columnar epithelium or crypts of Luschka, and the lamina propria. They form the muscularis propria, be circular, longitudinal, and oblique fibers, which are arranged in crossly section. And we have the subserosa, which contain the connective tissue, nerve, and lymphatics and vessels of the ducts. And the serosa is covered all the gallbladder except on embedded areas. And the ducts contain the submucosa and the muscularis mucosa. So for investigation, the main investigation we use the spleen radiograph. We see in which case it can be helpful to see to use spleen radiograph mainly to be uh, for not for to aid in diagnostic but not comprehensively. We have ultrasound. Ultrasound. There is a formal that we do ultrasound, but there's this contrast enhanced ultrasound, which is used by injecting contrast while performing the ultrasound scan. It is good because it is able to differentiate sludge from a tumor and identifying perforation in cholecystitis and better at demonstrating hilar cholangiocarcinoma. We have CT, which is used for diagnostic and staging purposes. We have MRCP, which will be aids to characterize the biliary tree better than CT. We have ERCP, which is used as a diagnostic and the therapeutic for diagnostic and therapeutic purposes. We have indirect cholangiography and the endoscopic ultrasound and the nuclear imaging and HIDA scan. For the congenital abnormalities, we have developmental intrahepatic biliary anomalies. They will differ according to the variation. As we have seen, there is made a triple confluence where we have the right posterior sectoral duct, which join the fifth and the sixth segment, which will join the right anterior sectoral and main left hepatic duct. They join at the same level. It happens in 12% of people. We have indirect insertion of the right sectoral duct, which goes directly into the main bile duct. And there is a variant of the insertion of the right sectoral duct, which will enter into the left hepatic duct, which happens in 3% of population. And also there is right posterior sectoral duct, which meets the cystic duct or gallbladder meaca. We this variant, it is important to recognize them as radiologists and the surgeons, as radiologists while reporting, and the surgeons if they fail to recognize these variants, they may result in biliary leaks or impaired drainage, which will lead to cholangitis in post-operative patients. So we have extra hepatic biliary anomalies. There are quite a number. The important ones are agenesis of the gallbladder. We have the bilobar gallbladder. We have folded gallbladder, congenital diverticulum, or duplication of cystic duct with the unilocular gallbladder, or septum of gallbladder. So the anomalies of gallbladder position, it may be intrahepatic, suprahepatic, or retrohepatic site, or may herniate through the epiploic foramen. So these anomalies, if they complicate, they may carry a high morbidity. So for the biliary atresia, it is absent or severely deficient extrahepatic biliary. It is less common. It happens in about 1 to 10,000 live births. It is associated with polycythemia, cutis inversus or malnutrition, and absent IVC in about 30% of cases. And the patient usually present with prolonged elevated conjugated hyperbilirubinemia. So on ultrasound, we may see hypoplastic gallbladder or a cystic cavity at the porta hepatis and features of cirrhosis in early life. So as I said, it is a rare disorder. So this on this uh, image, you can, with the patient with severe atresia, we can see that there is no post contrast. We cannot see the intra hepatic duct. They are obliterated. So this contrast is passing into the lymphatic system, where it will allow the elimination of the bile, but this is a patient post-operatively where they treat with portoenterostomy or Kasai procedure. So for imaging of biliary atresia, there are some ultrasound findings. For presentation, as I said, there is prolonged bilirubin levels, and the patient will present with non-natural jaundice. So they be absent or abnormal small irregular gallbladder, the vast majority of patients, or we may see echogenic fibrous tissue, triangular cord sign, anterior to the portal vein at site of obliteration with the extrahepatic bile duct. We may not visualize the dilated bile ducts, and the liver ecotexture might be normal or cirrhotic. So in this transverse ultrasound scan, you can see this echogenic tissue. This is the site of expected common bile duct, and you can see this portal vein. So anterior to it, where we expect to see the common bile duct, you can see that it is replaced by this fibrous tissue. This is the sign that we call a triangular cord sign, which is consistent with the biliary atresia. So on injection of contrast, on cholangiopathy, cholangiography, you can see that there is this contrast into the gallbladder, but we cannot visualize well the intrahepatic. You don't see the intrahepatic duct with the contrast, and there is no signs of elimination of the contrast. So as we can see, there is persistence of a contrast without elimination. This suggestive of biliary atresia. So we scan at 15 and 30 minutes. There was no significant reduction of the contrast. Also on ultrasound, and we can visualize that there is this irregular shaped gallbladder. It is small, not distended. uh, along the this is in a neonate we presented with jaundice. So after fasting, you can see that the gallbladder is not distended and it has a irregular margins. This is also a suggestive of biliary atresia. This is this even if we can see portion of the gallbladder, which is small, it is called gallbladder ghost sign. There is incipitated bile or plaque syndrome. It presents in infants where they have jaundice, secondary to plaques of thickened bile or rarely obstructing calculi, and they have also patient alcoholic stool or white stool. It may due to prematurity or parental nutrition, hemolysis, or developmental cortical anomalies. So the radiological features may be similar to that of biliary atresia or choledochocyst. So the treatment is by saline irrigation or percutaneous cholangiography. And another congenital, it is choledochocyst, where patients, where it is a pathological aesthetic dilatation of the extrahepatic duct in childhood, meaning in infants. So the clinical findings will be jaundice, which will be due to obstruction or cholangitis. A patient will present with the abdominal pain, and the cholangiography will reveal a common pancreatic or biliary channel. It has types. There is four types where they are classified according to Danny classification, where you can see that for the uh, type 1, there is cystic dilatation of the extrahepatic duct, as you can visualize in green. There is this cystic dilatation, while in type 2, there is formation of a true diverticulum. You can see this diverticulum along the common bile duct with this neck. So you can visualize well this true diverticulum, this type 2. You have type 3, where there is ectasia or of an intramural extrabiliary duct, where we can visualize below at the sphincter OD, where there is dilatation of the extrahepatic bile duct. Uh, Type 4, it is grouped into, there is type 4A, where we have multiple. It consists of multiple and dilatation of the intrahepatic and the intra extrahepatic cystic duct, as we can visualize here in the right sectoral ducts, where we can visualize this intrahepatic ducts dilatation, while in this 4B we can visualize the intra and the extra hepatic dilatation, the cystic duct. Type 5, it is usually called Caroli disease, which is cystic dilatation of the intrahepatic duct. So if there is this dilatation of the intrahepatic duct, type 5 and hepatic fibrosis, it will lead to Caroli syndrome. So MRCP is the imaging modality of choice to identify a choledochocyst and the type of an abnormality and the incidence of biliary malignancy. Most commonly, it is adenocarcinoma, which is associated with the type 1 and type 4, where type 1 is around 68% and type 4, 21% associated with the adenocarcinoma. So on this URCP, we can visualize this type 1, where we can see this bile duct is dilatation, only the common bile duct dilatation. As we have seen, it is a type 1 Todani classification. On this MRCPT2 weighted sequence, we can also visualize this uh, right sectoral duct, the posterior and anterior, and this uh, left hepatic duct. But when going through the duodenum descending, we can see that the common bile duct has dilated. Also shows type 1 choledochocyst. So this URCP images, which shows the types of choledochocyst, how they appear. This is type 1, and type 2, which forms through the verticular, as you can see at the common bile duct through the verticulum, and type 3, where this is from dilatation at the extrahepatic uh, bile duct at the area of the sphincter, and type 4, where there is intrahepatic bile duct dilatation. So on ultrasound, also we may visualize the choledochocyst, where we will see uh, on this ultrasound, we can visualize this cystic mass with internal debris, which is arising at the porta hepatis. You can see that it is communicating with this intrahepatic duct, which are mildly dilated, and this is a type, as you can see, it is intrahepatic. I can visualize the gallbladder on the other side. It is intrahepatic. This will be a type 4 choledochocyst botanic classification. So on ERCP, we can visualize this fusiform dilatation of the common bile duct, and this we can visualize this intrahepatic duct with this fusiform dilatation of the intrahepatic duct at the entrance of the common bile duct into the pancreatic duct. And this will be also type 4 choledochocyst, because it has reached the intrahepatic bile duct. On coronal CT, this is an enhanced CT scan where we can visualize this fusiform dilatation of the extrahepatic bile duct, which is characteristic of type 1 choledochocyst. We have the Caroli disease, which is characterized by multifocal circular dilatation of intrahepatic bile duct, which spares the extrahepatic duct. So when there is biliary stasis due to this dilatation of the duct, it can lead to cholangitis or ductal caliculi and liver abscesses. So specific sonography appearance, we see the what's called central dot sign, which occurs when the dilated bile ducts they surround the hepatic vein, hepatic artery, and the portal vein, and they are associated with some congenital anomalies like polycystic kidney disease or congenital hepatic fibrosis. So as I said, they may complicate into a ductal caliculi or liver abscess or cholangitis. As also can lead to cholangiocarcinoma, as we have said, type 4 and type 1 are associated with the neoplastic transformation. So we may visualize on this axial contrasted CT scan, there is this massive intrahepatic bile duct dilatation, mainly into the right uh, hepatic duct. With this, you can visualize in the center, there is this hyperdense, well-defined area, which is the vessels, and this is what is called the central dot sign, which is characteristic of Caroli disease. On color Doppler ultrasound, we can see these vessels, but we can see this circular dilatation of the intrahepatic duct. Mainly, this, as we can see, it is in the left lobe. It is mainly affecting the left hepatic duct. So on MRI, T2 sequence, it better characterize the intrahepatic bile duct dilatation, where we can visualize it is more common, more prominent in the right lobe, which means it is affecting the right hepatic duct. And this also, it is a characteristic of coronary disease. On percutaneous transhepatic cholangiogram, we can see that there is this generalized dilatation of this intrahepatic uh, bile ducts, and continuing to the extrahepatic bile duct, you can visualize also there are also this dilatation, and this happen in patient. If this is happening uh, in severe form, it will affect also the liver parenchyma, where patient can have a hepatic fibrosis in patient born with a defect. There is gallstone and there also choledocholithiasis. So when there is gallstone, there is this concretion of caliculi within the biliary system, and when there is choledocholithiasis, there is a concretion into the common bile duct. So the patient will have right upper quadrant pain, discomfort after fatty meal. They may be asymptomatic and we found during routine imaging. And the complication may include acute or chronic cholecystitis, cholelithiasis, cholangitis, or pancreatitis, or if it perforates into the small bowel, it may reach, the stone may go into the bowel, causing gallstone ileus, present with the signs and symptoms of small bowel obstruction. So for the imaging of gallstone, ultrasound high sensitivity and specificity for stone greater than 2 millimeters, where we see the high reflective intramural structure with the posterior shadowing, and it will be gravity dependent and mobile while changing position of the patient. And when there is a collection of bright echoes with acoustic shadow in the gallbladder, it may represent a gallbladder packed with stone, which can mistake for the adenobulb. So when there is what we call double arc shadow sign or walk wall echo shadow, or in short west sign, where we can see the two echogenic linear lines which are separated by a sonolucent line, anterior gallbladder wall, which is the anterior gallbladder wall, and the bile in the middle, and the curvilinear echo from the stone, and then the shadow. So on a plain radiograph, we may see radio-opaque stone. When there are radio-opaque stone, we may see them in about 10 to 20%, or we may see what we call Mercedes-Benz sign, which is gas within the central fissure of the stone. Well, this does not imply infection or complication. On MRI, mainly the T2 sequence, where we see small focus of signal void or low signal outlined by marked hypertense bile within gallbladder, and the URCP and the MRCP are superior for bile duct stone. On this transverse ultrasound, we can visualize this hyperechoic intraluminal lesion which is not adhering to the gallbladder wall, and they're showing this posterior shadowing, which is consistent of a gallstone. On this contrasted in CT scan axial, we can see what we call the Mercedes Benz sign. So we see this, it is a large stone, and we can see this very cholecystic fluid around the gallbladder wall, and this stone, which is also suggestive of gallstone on CT. On this ERCP, we can so to pen radiography, we can visualize this the NG tube, but we can visualize this radiopaque stone, which are uh, which are which are fused, mainly filling the gallbladder. Mm, We can visualize them, and we can also conclude on gallstone on plain radiography. We on this coronal enhanced CT scan, we can visualize here in the can visualize the gallbladder, but we can see well the common bile duct. But in the distal portion of the common bile duct, we can see this uh, hyperdense lesion with surrounding bile. You can see around the bile, and with this mild proximal dilatation of the extrahepatic bile duct. On this URCP post-contrast injection, you can see that there is this well-defined filling defect with the surrounding contrast, which shows this that it is a stone which is not getting contrast, and the contrast surround the stone in the common bile duct. There is a biliary sludge, which is suspension of particulate material bile in the gallbladder. It is seen as layering mobile material independent of a portion of the gallbladder. It has variable echogenicity with no acoustic shadowing, which is opposite to the gallstone. It may have mass-like appearance, which is called tumefactive sludge, but on a Doppler interrogation, it is B negative and B mobile. For the differential diagnosis, we have gallbladder intraluminal polyp or cholesterol polyp, or gallbladder carcinoma, and the gallbladder adenomyomatosis and emphysematous cholecystitis. So this is a biliary sludge. You can see this anechoic content, which is the bile, and we have this uh, biliary sludge. As you can see, it is not adhering to the gallbladder wall, and it is showing this posterior enhancement, which is in favor of biliary sludge or tumefactive biliary sludge. And on Doppler interrogation, it should show negative Doppler flow. On this also image, you can visualize that there is this uh, bile sludge, but it is surrounded by the bile, and it is not dependent on this bile gallbladder wall, which is showing that this is a bile sludge because it is not adhering to the bile wall, and it is not showing posterior shadowing, and it goes in favor of bile sludge. This is the same image, but on Doppler interrogation, we can see that there is no color flow inside the sludge. So if the mass was not mobile and showing positive color flow, it will be suggestive of malignant process. So the mobility and the color flow, the ones that differentiate it from the malignant processes of the gallbladder. So on this image, we can see that in this sagittal ultrasound, you can see that this mixed echogenic fluid filling the gallbladder lumen. Also, it is consistent of biliary sludge, and it can, as we comparing this, it looks more hypoechoic than this, which looks more hyperechoic. So it will take different appearance, but we rely on the mobility and the vascularity. So we have the gallbladder hydrops, where we can use ultrasound, where we see a distended gallbladder with anechoic and simple content. So the gallbladder wall will be normal, and there will be negative sonographic Murphy sign, and it may be associated with the gallstone. On contrast enhanced CT scan, there will be this distended gallbladder fluid with low density content. There will be no wall thickening and no pericholecystic fluid collection or adjacent fluid stranding. We can see this gallbladder hydrops. We can see it is gallbladder is distended. However, it is only containing anechoic content with posterior enhancement. This case of gallbladder hydrops. So this is was in a child with Kawasaki's disease, which predisposes to gallbladder hydrops. In this contrasted axial enhanced CT scan, it was in a cirrhotic patient. You can see this distended gallbladder with normal wall thickening and no pericholecystic fluid collection or adjacent fat stranding. However, we can see this hyperdense, well-defined lesion in the area of the cystic duct. So this gallbladder hydrops was due to obstruction from the cystic duct. So also on this ultrasound scan, we can, this was a patient who was having primary cholangitis, but you can see that there is this anechoic content in the gallbladder with posterior enhancement suggestive of gallbladder hydrops. On this T1 sequence axial, we can visualize that the gallbladder is not taking contrast, but we can see this dilated cystic duct, and which was due to uh, a cystic duct obstruction, which has led to the gallbladder hydrops. Uh, and so on this ultrasound image, we can. This was a patient who underwent renal transplant, and he developed this distended gallbladder, but there is this a mild wall thickening, can see here superiorly, with this deposit echogenic material, and for this one, he was having a positive Murphy sign, which is usually not characteristic of gallbladder hydrops. So if you see not anechoic, which is mixed, you can see this anechoic bile and this deposits echogenic content, and with this with the positive Murphy sign, so it will not be a gallbladder hydrops. So we will think maybe of cholecystitis or complication related to cholecystitis. So we have calculus cholecystitis.
Excuse me, Thierry.
Yes,
Excuse me, Thierry.
yes, I understand.
Can you come back a bit?
Yes.
Uh-huh. I didn't see. I didn't see to which extent will you call? Will you say that this is a high drop in terms of measurements? Gallbladder hydro.
So we see if this distended. Hello?
At which extent means the long axis, how much long axis, how much short axis, because
So we will
for
calculate.
you to call this,
So we will calculate the measurement of the.
mm,
Hello?
normally beyond the 9 centimeter long axis, now you can start calling it hydro. Short axis be beyond the 4. Okay,
Hello? I didn't get you.
if I will really to beyond the 9, okay, you you're gonna check it.
Okay.
Video.
It's
Let's go on.
so for the calculus cholecystitis, it is that for when there is calculi obstructing the cystic duct and it will cause infection of static bile and the gallbladder mucosa. So we will be have to be able to differentiate acute from chronic cholecystitis. So on CT, we may see this dense stone, which made of calcium, as described, called biliary stone. We may see Mercedes base sign on hepatobiliary. We may use hepatobiliary scintigraph, and when there is no visualization of the gallbladder after 4 hours of radio tracer, after injecting a radio tracer, also we may suspect cholecystitis, but considering also the clinical sign. So in this patient, we can see that on ultrasound, the transverse scan, we can see this echogenic stone with posterior shadowing, but around we can see this thickened gallbladder wall with this minimal surrounding fat stranding, which is suggestive of calculus cholecystitis. And this after injecting radiotracer in old man, in old woman, we can see that there is this surrounding edema here in white, which is also suggestive of acute cholecystitis. So this acute cholecystitis, if there is the bile is retained into the gallbladder, so when we start to call it chronic, when there is this distension of the gallbladder due to stasis of the bile and the recurrent episodes or bouts of acute cholecystitis. On this CT, you can see this Mercedes-Benz sign, which we can see at this level, where also there is surrounding a pericholecystic fat stranding. There is also calculus cholecystitis on ultrasound. As I have said, is this see this echogenic intramural foci, which is a stone, and the mirror thickening should be above 3 millimeter. You should see this pericholecystic correction or in the later stage abscess, and the positive tenderness on ultrasound scanning, and the gallbladder distension may reach around 5 centimeter in short axis, and gallbladder wall striation, which may be present or not, and on Doppler interrogation will be hyperemia of the gallbladder wall. For the chronic cholecystitis, it results when there's this contracted gallbladder, when resulting from obliteration of the lumen in spite of the patient who has fasted. We can visualize on this contrasted axial CT scan this uh, thickened gallbladder wall. We can visualize this a small hyperdense stone with this surrounding fat surrounding and edema around the gallbladder. And on this also axial constructed CT scan, we can visualize this surrounding fat surrounding around the gallbladder wall and the edema and this thickened gallbladder, this thickened gallbladder wall. So all these are in favor of calculus cholecystitis. If you visualize this, there is on ultrasound, there are some tiny stone, but which can visualize, which will be mobile on on ultrasound, and there is this gallbladder thickening, which should be above 3 millimeters, and which is in favor of cholecystitis. If there's a stone, it will be calculus. There is also acaricious cholecystitis, which is that from 5% of cases of acute cholecystitis, which occur in absence of gallstone. It may be due to ischemia, a gallbladder infection, or cystic duct obstruction. It usually occurs in sick patient after major surgery or extensive trauma, or patient with prolonged parental nutrition, and it has a clinical presentation of sepsis. So on ultrasound, you see this gallbladder distension with gallbladder wall thickening and the echogenic content inside the gallbladder lumen, and with the pericholecystic fluid collection or fat stranding. So it has a complication. It may lead to gangrenous cholecystitis, which is be due to increased intraluminal pressure leading to gallbladder wall ischemia. And in imaging, we see this gallbladder wall thickening, which may not be asymmetric, and the intraluminal uh, membranes may be present, and it is due to increased risk of perforation. So they have to treat it as emergency with the cholecystectomy or cholecystotomy. So it may complicate to gallbladder perforation, which has a high morbidity, and it will lead to generalized peritonitis. Or perforation may also perforate into the a small bowel where it will cause the cholecystoenteric fistula. There is emphysematous cholecystitis, which is severe complication of cholecystitis which due to gas-forming bacteria. So the gas may be seen within the lumen or the wall of the gallbladder. So the patient will be susceptible to one of the predisposing factor is diabetic patient, and early treatment is crucial. So on imaging for inflammatory cholecystitis, as I've said, we see gas in the lumen on the wall of the gallbladder. So CT is the best modality to identify this ectopic gas and make a quick diagnosis. While gangrenous cholecystitis, we see small isolation or outpushing into the gallbladder wall and the intraluminal linear membrane secondary to sloughed mucosa. So if in acute cholecystitis, the local this inflammatory reaction involves the common hepatic or common bile duct to lead to Merusi syndrome. So in this contrasted axial CT scan, we can see that there is this, you can visualize this distended gallbladder with this pericholecystic fat surrounding adjacent to the gallbladder wall. So As we can see, there is no other uh, signs. We can there's no ecogenic material within the gallbladder lumen, so we can conclude on acalculous cholecystitis. On this transverse ultrasound scan, we can see that this distended gallbladder with regular wall thickening. You can see it is irregular, which shows that this is a site of perforation with a fluid collection around the wall. Uh, this also is a sign of acalculous cholecystitis, but which may lead this fluid may lead to a formation of pus around the gallbladder. And below on this ultrasound image, you can see that there is this irregular gallbladder wall, uh, which is thickened with a echogenic content bile, with this also the mucosa, as you can see, it is not very linear as a normal uh, gallbladder wall. So this is also, and there is no sign of a hyperechoic lesion with posterior shadowing. So there is no stone, which is suggestive also of acalculous cholecystitis. The same in this patient, where we can visualize this. You can see the wall of the gallbladder, which is edematous, and we can also visualize around the wall. You can visualize that there is a surrounding gas. This is in a cholecystitis, but with which was becoming gangrenous. We have emphysematous cholecystitis, which is infection from gas forming, as I said, organism. Mainly it is Clostridium within the gallbladder wall on lumen. It, as I've said, the predisposing factor, they are diabetic and the other immunocompromised patient. So perforation is 5 times more likely if it is due to calculus cholecystitis, and we see a gas shadow from the wall and the lumen of gallbladder with gas fluid level on erect posture. Sonographically, you may see bright reflection from a non-dependent part of the gallbladder wall, and the associated accused shadow is usually dirty, and in many cases, this ring down artifact, which is a sign of gas. So on this plain radiography, we can see this is the gallbladder, but we can visualize where we could see the wall. There is area which is surrounding the gallbladder. So this is a case of emphysematous cholecystitis, which can be seen on brain radiography. On uh, coronal CT scan, we can visualize the lumen of the gallbladder, but we can see the gas inside the wall of the gallbladder, which is a case of emphysematous cholecystitis. On ultrasound scan, this is gas with the link down artifact at the area of the gallbladder, which is a sign of emphysematous cholecystitis. So, and this also ultrasound image, this was a diabetic patient. You can see that there is this dirty this dirty uh, shadow where we can see here we can see the gallbladder, but this uh, a high reflective uh, gas around the gallbladder, which is suggestive also of emphysematous cholecystitis. And we can be demonstrated where in this case we are not seeing entirely the gallbladder. We can see the gas around the gallbladder, but we cannot identify clearly the gallbladder wall. Here it was in the case of a perforation, which was had led to gangrenous, which was due to gangrenous wall, and it has perforated. That's why we are seeing this gas around. On ultrasound, also the on color Doppler, it should not inside, it should be negative, but outside, as it is an inflammatory process, will be having a high signal on color Doppler sonography. And with this high intensity echoes within the gallbladder, which are in keeping with the emphysematous cholecystitis. So also it is the same in this patient where we can see it is the comparing with this, the air was in the wall and the air is in the gallbladder lumen. Also a case of emphysematous cholecystitis. There is Meniere's syndrome, which is characterized by common duct narrowing by inflammation and fibrosis, which is related to chronic gallstone. Typically, a stone will be impacted in the neck of the gallbladder or the cystic duct. This will cause subsequent compression of the common hepatic duct, and the resultant inflammation are the mechanism that will lead to Meniere's syndrome. So also a fairly low insertion of the cystic duct into the common hepatic duct may predispose to Meniere's syndrome. On imaging, on URCP, we see the extrinsic narrowing of the common hepatic duct. We see the irritated intrahepatic duct and lack of gallbladder opacification. And the impression on common hepatic duct is often concave to the right. On the MRI, it's the same. We see dilated intrahepatic duct and the extrahepatic with the structure at the level of the stone, which will be characterized by signal void node sequences. And while on ultrasound, we see this stone, which is large, immobile, and where it is impacted mainly the cystic duct. So there is differentials which include the choroidocholithiasis. So this diagram illustrates this uh, stone which is impacted into the cystic duct, and the resultant compression, it is considered it is compressing the lumen of the common hepatic duct, and the cause subsequent the proximal dilatation of the intrahepatic duct. So which is the same we can see on CT, sorry, on MRI. You can see this signal void, but which is associated with the proximal dilatation of the intrahepatic bile duct. On axial CT, we can see that there is this uh, distended gallbladder with this with the, this distended gallbladder, and it can show this thickened gallbladder wall. We can see surrounding a small fatty stranding, and when they do uh, URCP, we can visualize this filling defect in the common bile duct and with subsequent dilatation of the proximal intrahepatic bile duct favoring the Meniere's syndrome. And MRI, as we can see, there is this at, at the common hepatic duct. We can see that there is this signal void and a severe narrowing with the distal portion of the bile duct, but proximally we can see there is this dilatation of the right and the left intrahepatic bile duct, which also suggestive of Meniere's syndrome. And on ERCP, you can see this gap, which is a defect of a stone into the common hepatic duct as we visualize the left and the right hepatic duct, which are severely dilated. There is gallstone eros, which is also a complication of calculus cholecystitis. It is a rare complication, but it occurs where there is a perforation and the gallstone passes through the small bowel, that fistula between the gallbladder and the small bowel. It usually occurs at the level of the ileum, and before it can, the stone will be impacted at the ileocecal valve where it will cause sign and symptom of intestinal obstruction. So there is a triad, which is Riga triad, which uh, suggests of gallstone illness, where patient present with acute symptom of small bowel obstruction, and we see gas into the biliary and a stone into the any portion of the small bowel. It may be located in the right iliac fossa when it has impacted in the ileocecal valve. So in this patient, in the plain abdominal X-ray, we can see this dilated small bowel. But if you see below down the pelvis, you you can see this ovoid structure which is calcified, and with and when we look at the area, this is where it is this density, soft tissue density, the soft tissue density of the liver, where we can see gas within the biliary tree, and it will be consistent with gallstone ileus, as there is that this stone into the small bowel and the distended bowels, and this gas into the biliary tree. This coronosity, we can visualize this collapsed gallbladder. We can see the second portion of the duodenum, and we can see where this cholecystoenteric fistula, which where the gallbladder is joining the second portion of the duodenum, where the gallstone will pass through to get into the bowels. There is the porcine gallbladder. On imaging, we find that there is echogenic cavernous structures in GB fossa with this acoustic shadowing. With this acoustic shadowing, they show clean posterior acoustic shadow, no dirty shadow to suggest emphysema, and may show all echo shadow complex, which is seen, which is seen in the stone. They be by convex calcification involving the gallbladder wall with visualization of the posterior wall of the gallbladder. So they may see also cause foci of calcification into the gallbladder wall with acoustic shadowing. While on CT we see this calcification in the gallbladder wall that can be thin or thick and irregular, and they may involve the entire wall of the gallbladder. So this is an ultrasound where we can see this calcification, which are involving the entire gallbladder wall with this posterior shadowing, because it is the calcification which are suggestive of porcelain gallbladder. And so we can visualize it on this plain radiography, where we can visualize the at the area of the liver. We can also see this well-defined lesion with the calcified wall, which is suggestive of porcelain gallbladder. So here also we can visualize it is not occupying all the gallbladder wall, but we can visualize the superior and the inferior surfaces of the gallbladder wall. They are calcified in posterior shadowing, and there is no intraluminal stones, which is suggestive of porcelain gallbladder. This on CT, it is garrison with this calcified gallbladder, but no surrounding, fat surrounding, or pericholcystic fluid collection. There's what we call milk of bile calcium.
Dr. Thierry, I have difficulty to hear you. Can you raise please your voice?
Yes. So there is this milk of calcium bile, which is due to high density calcium carbonate precipitate within the gallbladder lumen. On ultrasound, we see mixed echogenicity, a layering material within the gallbladder, which might cause acoustic shadowing. The echogenicity is slightly higher than typical sludge, but it may be indistinguishable from sludge if there is no shadowing. And in some cases, it may present with the gallstone. On imaging, a biopacification of the gallbladder with high density radiopaque fluid, and we see fluid level on plain radiography. On CT, we see this high attenuation of the milky bile, which will be above 150, while on MRI we have low signal intensity on T2, and it be layers dependent. So this is the case of milky bile. On this plain radiography, we can see this extensive, you see it appear hyperdense, and you can see it takes the shape of the gallbladder, and you can see here in the intrahepatic duct, and this is a case of milky bile. You can visualize well here. It is very, it is has a white, it is hyper intense, and as you can see, it is also characteristic of milky bile. While on ultrasound, to differentiate it from biliary sludge, you can see that this it is filling the gallbladder lumen, and it has some posterior shadowing, if you can see clearly here, which is different from the biliary sludge. As we have seen, the biliary sludge, they show a posterior enhancement. So this will be a case of milky bile, and it will also be gravity dependent, but the posterior characteristic will be the one differentiating them from the biliary sludge. On this axial CT scan, we can see this calcification in the wall and the intraluminal of the gallbladder, which is also associated with the gallstone, those milky calcium gallstone. There is some inflammatory process where you have primary sclerosing cholangitis, which is immune-mediated disease causing progressive inflammation, fibrosis, and stricturing of intrahepatic and extrahepatic duct. This condition it is predominant in male, and it is associated with ulcerative colitis, and it can progress to biliary cirrhosis and hepatic failure. Uh, they say that it is predisposing to bile duct cancer, and on cholangiography to demonstrate multiple structuring of bile duct structures of extrahepatic bile duct may be long or short or multiple, while on CT on ultrasound we see segmental duct dilatation and increased predictor effectivity. We might see regional lymphadenopathies. This may be associated with features of cirrhosis and portal hypertension. So on this MRCP, this is a patient who has this. If you can see very well, this the right and the left intrahepatic duct, and we see the common hepatic and the common bile duct and the cystic. So we see that in this intrahepatic duct, they are not. We can see that there are some areas where you can see that there are like some signal void. These are structures, small structures of the intrahepatic duct. But for the extrahepatic duct, you can see that there is not predominant uh, sigmovoid, which seems to be normal. So this is a patient who presented with the sign and symptom of a primary sclerosing cholangitis. These are due to repetitive uh, inflammatory reaction from in the uh, intrahepatic or extrahepatic bile duct. Also, we can visualize on this URCP uh, that you have this. Can see here there is a structure. Can visualize this structure where it is located into the intrahepatic duct, and it is mainly into the left hepatic duct. And you can see there is this opacification, but when the on the proximal part, you can visualize that there is bile. The bile duct are well opacified, but at this level, there is narrowing of the lumen of the left intrahepatic bile duct. So on this patient, we can see that the extra and the intrahepatic duct are mainly involved. We can see that the very narrow lumen, which is characteristic of sclerosing cholangitis. So we have xanthogranulomatous cholecystitis. It is an common destructive variant of chronic cholecystitis, which is characterized by lipid-laden inflammation. It is due to many be due to as a complication of chronic cholecystitis, where there be due to the mucosal ulceration in a chronic uh, cystitis, the mucosa will perforate, and there be a penetration of the bile into the gallbladder wall, and this gallbladder wall which is perforated, the, and the bile into the gallbladder wall to form what we call xanthogranuloma. So this xanthogranuloma, they are the one that we lead to xanthogranulomatous cholecystitis, but if they are not treated, they may form abscess. So we may see an abscess as a complication of this xanthogranulomatous cholecystitis. So on imaging, we see this marked gallbladder wall thickening. We see this intramural hypoechoic nodule or bands, and we see a continuous mucosal line, and they have absence of hepatic invasion and biliary dilatation, and you may see gallstone. And when there is infiltrative, you see involvement of adjacent surrounding fat or soft tissue, which will be obliterating. So operative differentiation from gallbladder carcinoma is usually impossible. So from CT, we see that there is this gallbladder wall, which will be focal or diffuse thickening. We have polycholesistic fluid and inflammatory changes around the gallbladder wall, which may lead to abscess formation if untreated. The inflammation may extend into the adjacent liver and mimic gallbladder cancer with hepatic uh, invasion. And on MRI also we see this gallbladder thickening. And then on this contrasted axial CT scan, we can visualize this thickened gallbladder wall, mainly at the level of the fundus. So we can see that there is this, if you see where in in gallbladder fundus, it's like there is a mass which is enhancing, so which may make suspicion of a gallbladder cancer. but was in a case of xanthogranulomatous cholecystitis. Also, we can visualize on this axial CT scan. There is this gallbladder wall thickening, and you can see this pericholecystic collection, and you can see these intramural nodules, which are hypoechoic, which these intramural nodules are the one which will lead to abscess formation in a complicated xanthogranulomatous cholecystitis. We have also recurrent pyogenic cholangitis, which is a manifestation of chronic parasitic infection in the bile ducts from parasites, including Clonoechis senses and Ascaris lumbricoides. So these repeated bouts of cholangitis, they are the ones that will damage the intraluminal gall ducts, which will lead to multifocal structure and the super infection, and they be super-infected with bacteria, and there be formation of the stones. So the imaging triad of recurrent pyogenic cholangitis, we have pneumobilia, we have laminated bile duct filling defect, and we have intra and extrahepatic duct dilatation and the strictures. So patients with recurrent pyogenic cholangitis, they have an increased risk of cholangiocarcinoma. So on this ultrasound and Doppler, we can visualize this intrahepatic duct with this uh, echogenic lesion. We can see that it is showing posterior acoustic shadowing, and this was in of a patient with the recurrent pyogenic cholangitis, where we can see that there is increased vascularity and this dilated duct, and it was associated with stone as we have seen. On this T2 sequence MRI, we can visualize that there is a dilatation. If you compare with the anterior sectoral duct, right anterior sectoral duct, you can see that this posterior sectoral duct is dilated, and we can see that it is irregular, and with a with some signal void inside, which are characteristic of a stone which has caused obstruction and causing a subsequent dilatation of the sectoral duct. So these graphics represent this dilatation of the common bile duct from the intrahepatic going to the common bile duct extrahepatic. Due to you can visualize this filling defect stone. So this was recurrent pyogenic cholangitis. So this distended gallbladder and stone, and the hyperemia was in favor of recurrent pyogenic cholangitis. And ERCP, also we can appreciate that there is filling defects, but surrounding the contrast, which was in favor of cholangitis. On ERCP, MRCP, we can visualize this also signal void in the mainly in the left hepatic duct with a severe dilatation of the duct, and a characteristic also of pyogenic cholangitis. There is what we call ascending cholangitis, where the pyogenic inflammation of the biliary, as the result, the obstruction will lead to ascending infection going in the upward stream in the biliary tree. So the presentation will be for charcoal triad where patient will have fever, jaundice, and pain. So on imaging, you have dilatation also of the intra or extrahepatic bile duct, and we may see the bile duct which is has wall thickening or hyperenhancement. We see intraductopurulent bile or pus, which will show as high density on CT and intermediate to low signal on T1 and T2 weighted images on MRI. Or we may see an heterogeneous liver enhancement, which can be wedge-shaped, peribiliary, patchy, or diffuse. It may be associated with liver abscess or protovenous thrombosis. So on ultrasound, we see dilatation, stenosis, and thickening of bile duct wall with the intraimmuno echogenic debris, which is show that it's purulent bile. So on this oblique uh, view on ultrasound, where we can see that there is this obstructing stone. If you're seeing it, maybe here we can visualize it well. There is this obstructing stone, and we can see that there is this hyperechoic area in the area of the common bile duct, uh, which is co- which is showing that it is cholangitis, but as it is retrograde, it is a ascending cholangitis as it is from distal going to the upward uh, biliary tree. On this image, transhepatic cholangiography, we can visualize the sectoral segmentoducts where they are fusing to form the right hepatic duct. But when you see very well, you can see that there is area of obstruction with no. You can see that there is no continuous flow of the of the contrast going to the duodenum, and with the subsequent mild dilatation of the proximal intrahepatic bile duct. While on CT axial cut, you can visualize this mainly a right lobe, a severely dilated intrahepatic bile duct. So on this coronal NCT scan, we can visualize the common bile duct, but when you can see this soft tissue enhancing, it's like a mass with uh, enhancing common bile duct wall and dilatation, suggestive also of ascending cholangitis with surrounding pericholecystic fat stranding. We can also see here this is the duodenum, the second portion of the duodenum, but we can see this gallbladder, this common bile duct wall, which is enhancing, thickened with proximal dilatation upstream, showing with the surrounding pericholecystic stranding, uh, which is showing also a case of ascending cholangitis. It is also the same with this patient where we can see that the wall of the extrahepatic bile duct is enhancing, dilated with surrounding uh, edema. So we have what we call HIV cholangiopathy. It may due to secondary sclerosing cholangitis, and it presents in patients with HIV with low CD4 count. So ultrasound can exclude other causes of pain and the cholestasis with the high sensitivity for identifying cholangiopathy. The finding will include bile duct wall thickening, enhancing focal strictures, and it will resemble mostly for primary sclerosing cholangitis and duct irritation, and it may lead to papillary stenosis. So the gallbladder wall thickening is very common. So this is a diagram which shows this gallbladder wall thickening and intra and extra hepatic duct wall thickening. So this is a ultrasound at the area of the portal hepatis, where we can see that the common bile duct is dilated with the distally there is this abrupt tapering. You can see that you don't see the continuation of the common bile duct, and with this proximal dilatation, but however there is no surrounding uh, edema or stranding, which is due to an HIV patient, which is due to HIV cholangiopathy. Also, on this patient, you can see in the right lobe, we can see that this duct, this is dilated, and all those ducts are dilated. We can visualize that the wall is thickened, which looks hypoechoic. In HIV patient is suggestive of HIV cholangiopathy. And on ERCP, you can see that at this can see the common bile duct, but there is this abrupt tapering, and with the subsequent upstream dilatation in HIV patient also with no surrounding inflammatory reaction, so it's suggestive of HIV cholangiopathy. There are some vascular disorders. There are some due to non-astomatic biliary strictures in a patient who have underwent liver grafting, and they occur as hepatic artery thrombosis or stenosis, but they occur, but a large variety occur in microangiopathy and immunological injuries. So the imaging, they involve mainly the middle one-third of the common bile duct and the hepatic duct confluence. So the gold standard of diagnosis is cholangiography, where it is appears as a primary sclerosing cholangiopathy with this beading biliary tree, this beading which shows alternating stenosis, normal dilatation, and alternating stenosis. So this bill casts appear as filling defect within the duct lumen. And CT we may see scattered irregular biliary dilatation with bile duct wall thickening and enhancement. So the presence of intrahepatic myeloma or liver infarct should prompt a careful assessment. So on this, you can CT scan, we can visualize that this is the abdominal aorta, but we can see that this, if you visualize well the hepatic artery, right, to originate from the celiac trunk, you can see that it is severely stenosed, and this was due to invasion of the hepatic artery, which had led to ischemic cholangiopathy of the hepatic artery, and it has been occluded, and it was resultant from, and and there is a stricture which was resultant from the common bile duct. So also we can visualize on this ERCP, when a patient post liver transplant, we can see that there is irregular intrahepatic bile ducts, and from at this junction, at this level of the common hepatic duct, we can see that there is the like a filling defect, and which was due to a filling defect where the which was a filling defect, and this has complicated into portovenous thrombosis, which is not visualized here. On this MRI sequence, a T1 weighted image, you can see where the bifurcation of the duct, right hepatic duct, you can see that there is this high signal intensity and this uh, distal structure which has caused proximal dilatation and which is also a characteristic of ischemic cholangiopathy. There are some benign neoplasm and tumor-like condition. We have gallbladder polyp. The size is most important predictor of malignancy. When they are greater than 20 millimeters, it is suggestive of malignant, but when they are less than 10 millimeters, mostly 94% are benign. So the risk factors, they are age greater than 60, gallstone, and pre-existing primary sclerosing cholangitis. On imaging, we see immobile echogenic mucosal node with no acoustic shadow. They have large polyp may show internal color flow vascularity, and we saw this comb-tail artifact which suggests of polyp. While on CT, it is very useful for staging larger polyp where there is increased of malignancy, and we can see the variable degree of enhancement with no, but the enhancement doesn't correlate with the degree of malignancy. So on this ultrasound, we can see this small. They may vary to hyperechoic. They, they look nodular. They are attached to the gallbladder wall. They are immobile, and they may show uh, internal vascularity as the size increases. So as you have seen, those that less than 1 centimeter, they have a less malignancy transformation, which is about 94%. Also, this one we can see that it is it looks large, hyper echoic. It looks attached to the gallbladder wall, and it is immobile, and it looks when and it is immobile, and there is no posterior enhancement. So for if there is also for the gallbladder polyp, if for the follow-up the size is usually stable, it doesn't grow, so it is also suggestive of benign polyp. But if there is increase in size, there will be high risk of malignant transformation. There is adenomyomatosis, which is a benign, usually asymptomatic condition that may produce diffuse or focal wall thickening due to round cell infiltration, muscle hypertrophy, and mucosal herniation into the muscular layer called Rokitansky-Ashkoff sinuses. On ultrasound, the cholesterol crystals deposited in the Rokitansky-Ashkoff sinuses result in bright reflection and short comic tail artifact arising from the gallbladder wall. On oral cholangiography, we may three types of findings. We may see fundonodular filling defect. We may see structure at the site of the gallbladder, where there is structure, or epithelial senescence, which may become apparent following contraction with contrast with small neurotivertical. So this is a case of adenomyomatosis. You can see this comet tail uh, artifact from the superficial wall of the gallbladder, which is the consistence of adenomyomatosis. So it has resulted from this uh, focal wall thickening with the infiltration of cell, and this on echography, and we see this comet tail artifact. So we have this Yeah, on the fundus, you can see that there is fundus area where it is more hypointense, with the which is a fundal nodule with an before and it was after and before gallbladder contraction. So there is this persistent focal lesion where there is no contrast feeling, which also is suggestive of adenomyomatosis. There is biliary hematoma. They are symptomatic and of no clinical signs. They appear as multiple innumerable cysts of water density. They are distributed in all lobes. They may have subcapsular or intraparenchymal location, and they don't have the majority don't have communication with the biliary tree, but some may communicate with the biliary tree. And they are short associated with autosomal dominant polycystic. Uh, Sometimes they may be associated with the polycystic liver disease. So as you them can see this small. Uh, they are diffuse and they're scattered in all lobes of the river. They are hyperechoic. You can see that there's no biliary tree dilatation, and we call them biliary hematoma. On CT, you can on contrasted and CT scan, they don't pick contrast, and as we said, water density they are cystic, and they don't communicate with the biliary tree. So and they are around vessels, and they here the majority in the right lobe of the liver. So they are small sized innumerable cysts scattered along the liver. On T1 image, you can see these hypointense lesions scattered in the whole liver, which are non-enhancing, which are small, suggestive of biliary hematoma. On T2, you can see very well that they are hyperintense, well-defined cystic lesion along the right lobe of the liver, suggestive of biliary hematoma, with no intra or extra hepatic bile duct dilatation and without any communication. You have biliary papillomatosis, which is a rare disorder characterized by multiple premalignant adenomatous papilloma tumors in intrahepatic or extrahepatic bile tree. So on cholangiogram, we see multiple round or overfilled defect in bile tree with regularity of adjacent bile duct wall. They can be intrahepatic or extrahepatic duct, and they range in size from a few millimeters to a few centimeters. And CT, we see the bile ductal dilatation due to obstruction or increased missing production. They appear hypodense, non-enhancing, uh, on contrasted NCT, while of MRI they appear in T1 hypointense and the mild T2 hypointense. While in ultrasound we see polypoid nodule without acoustic shadowing. So on this ERCP, this patient has elevated liver function. We can see that there is this like feeling defect in the common hepatic and the common bile duct, where you can see that they're not picking contrast and they are attached on the gallbladder wall with some irregularity, which are suggestive of biliary papillomatosis. Also on this MRCP, you can see this uh, hypointensity and in the common hepatic and the common bile duct adherent to the wall of the biliary duct, which is suggestive of biliary papillomatosis, and it appears as a small nodula, which is are focal in the duct lumen. On this coronal contrast, the common bile duct you can appreciate from proximal, but when you arrive at this level, there is a filling defect which appear as a soft tissue density which is nodular, which are adhering to the wall, which is suggestive of biliary papillomatosis. And it has a high risk of malignant transformation, which can result to invasive carcinoma. There are benign biliary structures. There are structures which may be post-surgical. Some may be to post-cholecystectomy, open or laparoscopic cholecystectomy. So they may cause bile duct injury with transection or devascularization. This may result to lead to biliary leak or stricture formation at the site of cystic duct or and it has at the, it has a high risk at the site of the cystic duct, and the biliary disconnection and the biliary drainage may result from the complication of surgery. There is low loop anastomosis to the common hepatic duct and portoanterostomy, which is Kasai operation, which is also an operation that carries a high risk of stricture formation. For patients with hepatic resection, also there is high risk of biliary stricture and the vascularization from the hepatic artery. So the strictures they occur in about 5 to 14% of patients with liver transplant. So on this MRCP, we can see this severe narrowing in the extrahepatic bile duct, which is suggestive of a stricture. Also, we can see on this MRCP this multi-segmental structures from the cystic duct. You can see how they form like a lobula, but they are extending along a long segment of the cystic duct. This biliary intraductal papilloma business neoplasia, which is intraductal papillary neoplasia, and it is a pre-invasive biliary neoplasm, and it is a precursor of cholangiocarcinoma. Patient present with abdominal pain, jaundice, and which are the main symptoms. And as we can see, there is inside the bile duct. It's where there is this proliferation of malignant tissues. So in ERCP, there will be extrusion of clear missing from papular ampulla visible endoscopically due to the missing tumors hypersecretion. While on CT, we see marked dilatation of the intra and extrahepatic bile duct with mirror nodularity or discrete intraductal mass. There be presence of mirror nodularity of soft tissue, which suggests of malignancy. So as you can see on this left hepatic duct, you can see it has regular wall and shape. They are all irregular, and with this intramural uh, non-enhancing lesion, which is adhering duct to the duct wall, and also it is, as you can see, it has a unclear margin. This also it has a high risk of malignity transformation, which is intraductal papillary neoplasm. As you can see clearly on this left hepatic duct, it is dilated with irregular walls, and this patient also you can see that inside there is this enhancing a soft tissue lesion, which is suggestive of also a malignant process. It may be intraductal malignant neoplasia or cholangiocarcinoma, so the pathology will be confirmatory, but imaging, we see the contours and the enhancement of the lesion. Also, we can see in this axial cut where there is in the left lobe, there is this, you can see that this duct is very dilated, and comparing to the adjacent duct, this one is very dilated due to an obstructing intraluminal mass. So there is malignant neoplasm and the tumor-like condition. There is cholangiocarcinoma, which is an adenocarcinoma which arises from the intrahepatic bile duct or extrahepatic bile duct epithelium. As we have seen, there is some benign, which may have malignant transformation. It develops at a young age, mostly present under 50, and it has male preponderance. It is slow growing and a locally invasive tumor with frequent involvement of the hepatic artery and portovenous system. Distant metastases are not common, and it occurs in about 12% of patients. And the prognosis of the tumor is very poor, and there are some people who are at increased risk. There are people with the autoimmune disease, as we have seen, primary sclerosing cholangitis, people with the selective cholangitis, or people with the primary biliary cirrhosis, or as we said, people with the choledochocyst, mainly type 1 or type 4, they are the one with the high risk of cholangiocarcinoma, and with the infection like biliary parasite or recurrent pyogenic cholangitis. All these diseases that uh, predisposed to intrahepatic or extrahepatic luminal injury, recurrent luminal injury, they predispose to malignant transformation of that area. So the patient may usually present with jaundice, pain, and fever. So, and usually this cholangiocarcinoma, it usually located at places where there is a increased uh, peribiliary gland. Those peribiliary glands, they are the one that contain those hepatic progenitor cells. So they are the one which will lead to the high proliferation of the malignant cells. So there are mainly those hepatic progenitor cells that are mainly located along the cystic duct, the biliary confluence, and the periampullary region. So it's where we may see mainly the cholangiocarcinoma, but it can occur anywhere along the biliary tree. So the morphology, it may be infiltrative, exophytic, or papillary. So on this diagram, you can see at the confluence of the right and the hepatic duct, we can see that there is this mass which is invading the adjacent liver with the liver parenchyma and the hepatic veins, which is this, and this upward dilatation of the intrahepatic bile duct. So on ultrasound, the appearance depends on the anatomical location of the tumor and the tumor extension. When there is intrahepatic cholangiocarcinoma, it will present as a mass with ill-defined margin with the heterogeneous architecture. They be isolated thickened intrahepatic bile duct and intraductal mass with upstream ductal dilatation. when it is hilar cholangiocarcinoma, which is about 50%, also to present with intrahepatic bile duct dilatation without extrahepatic duct dilatation, because uh, the dilatation will go upstream, going into the liver, not extrahepatic. So they may be non-union of right and hepatic duct. So the primary tumor may not be discernible or appear small, infiltrative, or hypoechoic mass in higher region. It may be nodular or papillary mass in the duct. On this color Doppler ultrasound, we can see that there is an isoechoic mass in the left lobe of the liver, and with associated upstream dilatation of the intrahepatic duct, and so the mass was causing obstruction with the upstream dilatation, with the also, and also it shows increased vascular flow. So on this oblique transabdominal ultrasound, we can see this ill-defined hypoechoic mass at the hepatic confluence, which has caused upstream dilatation of an intrahepatic duct in both lobes. On contrasted enhanced CT scan, we can visualize that there is this intrahepatic duct dilatation, but we can see this hypo, hypodense lesion with the irregular margin, which which has caused this upstream dilatation of the intrahepatic duct. This is also suggestive of cholangiocarcinoma. So on CT findings, mainly on the non-contrasted CT scan, we see mass may appear as hypodense, and it may show capsular retraction, and it may be of hilar location when it is intrahepatic, and extrahepatic, mainly located in the common duct, and it may be to grow. It is usually also hypodense with the intrahepatic bile duct dilatation. On contrasted CT scan, they show early limb enhancement with progressive central patchy enhancement, while in portovenous phase, there's minimal enhancement and the irregular thickening of the bile duct wall, and there is, depending on the degree, they may show invasion of portoven, which is seen mainly those of intrahepatic type. Or we may see surrounding enlarged portal lymph node, while in the delay phase, the enhancement will be have persistence enhancements due to the fibrous zone. On this T1 axial MRI, we can see that there is this in this portovenous phase. We can see that there is this hypointensity of the tumor, but there is this peripheral enhancement as it continues to centrally, but it is causing this dilatation of the adjacent duct, which is it was at the area of the confluence, which is also suggestive of cholangiocarcinoma. Also, we can visualize on this T2 image this mass, which is irregular, with dilatation of the intrahepatic duct. And this one, it was a patient who had a primary sclerosing cholangitis, which has progressed to cholangiocarcinoma, as there is this repetitive injury of the endothelium of the intrahepatic duct or intra or extrahepatic ducts. So the best imaging tool for cholangiocarcinoma, we have ERCP or MRCP. This ERCP and MRCP, they show extent of ductal involvement, while CT is mainly used for tumor extent, where we can see if there is a liver invasion and node involvement and distance metastasis. While for the ultrasound, we only be able to visualize if there is obstruction, but it will be difficult to characterize the obstruction depending on the level where the cholangiocarcinoma has occurred. So we have to see those intrahepatic or extrahepatic bile duct dilatation. So in this cholangiogram, and the confluence of the main and of the right and the left hepatic duct, we can see that there is marked dilatation of the hepatic duct, but there is this like defect, which is a mass at the area of the confluence. This mass suggestive also of cholangiocarcinoma. So this also is you can see at this level there is it's like a structure. This is what we call apical structure. This one, when the common bile duct, which is also characteristic of cholangiocarcinoma, which has resulted from a mass which has caused obstruction at that level, and they caused severe narrowing. So for staging of cholangiocarcinoma, it will depend on the site of the tumor. As you have seen, it may be intrahepatic, hilar, or extrahepatic. So we see the tumor size and the nodal environment and the distance metastasis. So this you can read about it. And you have four staging, and four categories of TNM staging. There is gallbladder carcinoma, which is malignant epithelial neoplasm arising from the gallbladder mucosa. So it is associated in 90% with the gallstone. It has a female predominance, and it is usually caused by some inflammatory diseases that predispose to gallbladder carcinoma, which include a porcine gallbladder, sclerosing cholangitis, and gallbladder polyp are some predisposing factor. So in ultrasound, we see this asymmetric gallbladder wall thickening will be it may be discrete and polypoid, and will be heterogeneous with the moderate echogenic gallbladder mass. It may show hepatic invasion with loss of normal echogenic gallbladder wall dividing the mass and the liver. It show a positive internal vascular flow on color Doppler, and the cholangiography will reveal biliary structuring, often in the intrahepatic dilatation. While on CT and MRI, we may have a mass which has completely replaced the gallbladder in two-thirds of cases, or irregular focal mass with diffuse gallbladder wall thickening. And typically the mass is hypodense in venous phase, but may have peripheral vascularity on arterial phase. It usually invades the liver and the porta hepatis. So the most common site of metastasis of gallbladder carcinoma are in the liver and the peritoneum. So calcified gallstone or porcine gallbladder may be present at the one of the predisposing factor. So on this axial CT scan, we can visualize this polypoid enhancing mass which is filling in the gallbladder lumen. On this mass, which is enhancing film the gallbladder lumen, it is associated with it is highly associated with the gallbladder carcinoma, And while on ultrasound, we can visualize that this mass, you can see this mass which is appears as hyperechoic, which is attached to the wall and associated with this porcelain gallbladder wall, mainly affecting the superior gallbladder wall. And this is highly suggestive of gallbladder cancer. So on this MRI, a T2-weighted sequence, you can see this irregular gallbladder wall, which is hypointense, irregularity with the gallbladder filled with with bile, but no surrounding perichorecystic correction, highly suggestive of intra of gallbladder carcinoma, and you can see that here it has metastasis in the surrounding liver parenchyma. There is ampullary carcinoma, which is a heterogeneous group of malignant epithelial neoplasm which arise from the ampulla of vata. So it is seen as soft tissue mass centered in the region of the ampulla of vata, overlying the periampular duodenomicosa. So we will see a double duct sign with obstruction of the, which represents the obstruction of the common bile duct and the pancreatic duct. So the mass may be well defined or infiltrative or ill-defined. So ultrasound, it may be a screening tool and for detection with patient biliary dilatation and the jaundice, but it be difficult to visualize the mass when it is at the ampulla region because of the bowels which will be above. For the ampullary mass, it is difficult to see on ultrasound, but endoscopically it is visualized, and endoscopic ultrasound endoscopically may guide for the biopsy and improve the accurate diagnosis. So the imaging tool is a contrasted NCT scan where we see mass with variable attenuation, which will be centered in the ampulla with the a cutoff of the common bile duct and the pancreatic duct, which will produce the double duct sign. You may see also small masses which may not be visible on ultrasound, and they may be only we may see the complication which will be the we may see on the secondary sign which will be the double duct sign, which will suggest that there is a mass obstructing at the level of the ampulla. While on MRI, we have a low T1 signal intensity and the intermediate to high signal intensity on T2, and with the same dilatation of the CBD and the pancreatic duct. As we can visualize, so the mass will be in this diagram. This divide is the ampulla of water, so the mass will be located at this area and the second portion of the duodenum. So it goes upstream dilatation of this pancreatic and the common bile duct. In this patient, we can visualize this dilatation of the common bile duct and the pancreatic duct with this soft tissue enhancing mass at the area of the at the ampulla region. So we can see that it is obstructing, and which is suggestive of ampullary carcinoma. It is the same in this patient where we can visualize this soft tissue mass with the common bile duct and pancreatic duct dilatation, suggestive of ampullary carcinoma. So they have biliary metastasis and lymphoma. So metastasis to gallbladder, usually they are polypoid enhancing nodule or mass within the gallbladder lumen, but may appear have focal thickening, while lymphoma of the gallbladder, they present as bulky mass with the low grade hypodense or homogeneous, while low-grade lymphoma may have mild wall thickening. So the majority of metastasis uh, from the gallbladder, they will arise from the uh, melanoma. Melanoma is the primary a cancer which metastasis into the gallbladder about 50%, while those that go metastasis into the biliary tree, mainly it will be literature they say it is colorectal cancer, but any cancer may metastasize, so you have to have a high index of suspicion. So for the metastasis, in this, you can see that in this patient, he had melanoma and he has this metastasis into the gallbladder. So in patient with the melanoma, if you have a gallbladder lesion, you should suspect that may primarily it is not a primary gallbladder mass, it may be a metastasis from the melanoma. So this is metastatic adenocarcinoma, where we can see a stricture along the common bile duct. You can see there is a severe narrowing at this level of the confluence with dilatation of the upstream tripartite duct and the gallbladder distension. So as a take-home message, so we have a very good appreciation of the pathological disease progression of the gallbladder and the biliary tree. Plus imaging, it is the one that will aid in better characterization of the lesion. As you can see, if there is no obstruction, you can think of these inflammatory and infectious causes. But when there is obstruction and strictures, depending on the clinical history and the context of the patient, we may think of neoplasm, post-inflammatory process, or the inflammatory causes of strictures. So these are my references. Thank you for the following questions. Are welcome.